So with that, I will ask us all to a round of applause to introduce Dr. David Murray. Thank you.
Thank you. So I know that I'm going to be speaking to many people in the room and watching over the webcast who are very familiar with these issues, others who are not. So this will be a mix of introductory material and some more advanced material. I thought I'd say a few words about pragmatic trials to start with. These terms have been around for a while. Pragmatic and explanatory trials were introduced in the late 60s. Explanatory trials test causal research hypotheses. Pragmatic trials help users choose between options for care. These terms are quite similar to terms that I've known about for a long, long time, coming out of Cochrane's work, efficacy and effectiveness trials. So explanatory trials and efficacy trials are quite similar. Pragmatic trials are quite similar to effectiveness trials. One of the things that makes the trials that we're talking about today special is that they all involve electronic health records. Electronic health records provide an opportunity to collect data for a research study at significantly reduced costs, and that's one of the reasons that motivated the Healthcare Systems Collaboratory, trying to find ways to do clinical trials at reduced cost. Of course, the data that are in the electronic health systems weren't collected originally for research purposes. You may not have all the variables that you want for your study. You may have limited control over the electronic health record system. So all of those things are barriers to getting research done using electronic health records. But if you do have some influence, they do provide a very efficient way to reach your target population. They can facilitate recruitment and follow-up. Participation can be flagged. You could use the EHR to help deliver the intervention, and certainly to collect data in a passive and less expensive way than setting up your own data collection operations. I would argue that pragmatic trials don't need a special set of research designs or measures or analytic methods, that we can use many of the methods that we use for other kinds of studies, and always the choice of the methods depends on the research question. So the research question dictates the intervention. That's a critical part in deciding what kind of design we're going to use. The target population, the variables of interest, those in turn dictate the setting, the design, the measures, the analytic methods. When I sit down with people to have a conversation I must have had 1,000 times, tell me about your study. It usually starts by tell me how the intervention is going to be delivered, who's going to do it, where is it going to happen, what kind of interaction are people going to have, with whom, and it's the way that that intervention is structured and delivered that often dictates the design that we're going to end up using. I certainly have the view that randomized trials provide the strongest evidence. We have a number of options for pragmatic trials that use randomization. We have other options that use randomization in some ways, perhaps not as completely as others. There are alternatives to randomized trials. I'm not going to speak about those today, but would be happy to do that in a separate conversation. Now I want to introduce David Murray's view of the division of randomized trials into three categories. We start with the familiar randomized clinical trial or individually randomized clinical trial. Here, individual participants are randomized to study conditions. They have nothing to do with one another post-randomization. They don't share an intervention agent. They don't meet in small groups. They may pass each other in the hallway as they're leaving a pharmacy or something, but there's essentially no contact, no expectation for interaction among participants after randomization. And this is very common in drug trials. We see this sort of design proposed in lots of other settings, just not necessarily appropriate for other settings. At the other end of the spectrum is the world that I usually live in, group randomized trials. Here, we're randomizing groups of some kind. They could be communities, they could be work sites, they could be schools, they could be counties, they could be states. So any kind of group, whether it's organized around geography or around shared interest, could be pre-existing. They could be created for the purpose of the study, but they're usually pre-existing. We expect that In these groups, the participants or members of the groups have been interacting with one another before we ever came along. They'll continue to interact with each other during the trial, and they'll continue to interact with each other after the study is over. In between is a category that is far less familiar, but certainly important and far more common than people believe or people realize. I call these individually randomized group treatment trials. They're sometimes called partially nested designs or partially clustered designs, just like group randomized trials are often called cluster randomized trials. Individually randomized group treatment trials start out just like RCTs. We have individual randomization of participants to study conditions or study arms. They separate themselves from the classic RCT because the participants interact with one another post-randomization. They may get some of their intervention in a small group on a Tuesday night or on a Saturday afternoon. They may interact with one another because they have the same intervention agent. They may not see each other face to face, but if they share the same intervention agent, they are effectively interacting with one another. They may interact with one another on a electronic chat room of some sort. So there's some sort of interaction post-randomization. These trials are extremely common in surgical studies, many behavioral trials. When I gave this presentation some years ago over at NHLBI, many of the people in the room were looking at the floor, recognizing how many studies they've funded that meet this design and weren't analyzed this way or structured this way. And I'm sure that would be true at many of the other ICs across the campus. I would identify two kinds of group randomized trials that we'll talk about today: the parallel group randomized trial, parallel intervention and control conditions throughout the trial, no crossover, and the stepped wedge, where all groups start in control. They cross over to intervention in a random order on a staggered schedule. All groups receive the intervention before the end of the study. So what's the impact of on the design of these kinds of things, and particularly when it comes to confounding? With randomized clinical trials, there's good opportunity for randomization to distribute potential confounders, so it's usually not a concern, especially in larger randomized clinical trials where there's no interaction post-randomization. In IRGTs, these tend to be smaller. There may be less opportunity for randomization to have the desired effect, so confounding may be more of a concern. In parallel group randomized trials, we often have a limited number of groups that we're randomizing. 10 years ago, I would have said usually less than 25. Now I'm going to revise that number and say, well, it's usually less than 50. So it's getting better. But if we randomize less than 20, 25 units to each of, to half to one arm and half to another arm, I'll promise you that those two study arms will be different on important factors that can affect the outcome. If we have 50 to randomize and we end up with 25 and 25, it's more likely that they'll be comparable, but there still could be something where there's a difference. And so confounding is a concern, especially in the smaller group randomized trials. In stepped wedge group randomized trials, because we cross groups with study conditions, that avoids most kinds of confounding, the sort that we usually worry about in the parallel group randomized trial. Even so, intervention effects are completely confounded with calendar time, as more groups are in the intervention condition late in the study, and they are, as a result, inherently less rigorous than parallel group randomized trials and should be considered only when a parallel group randomized trial is not appropriate. Some of the folks in the room and PIs on the Collaboratory started out thinking they were going to do a stepped wedge, and over the course of conversations changed to a group randomized trial. It is a better design if you can do it, but there may be reasons that push you towards the stepped wedge. What's the impact on analysis? And these issues are fairly well known for a group randomized trial, and they're quite similar for individually randomized group treatment trials. Observations on individuals who do not interact are independent. We can use the usual analytic methods. But if they are in the same group and have been in the same group as in a parallel group randomized trial, or they interact with one another in small groups as part of an individually randomized group treatment trial, there's going to be physical, geographic, social connections among these participants. And you'll either have an interclass correlation at the beginning of the study in a parallel group randomized trial, or it will develop over time in the individually randomized group treatment trial. Either way, observations among members in the same group or who share the same intervention agent will be correlated. That reduces the within-group correlation, but it creates a separate between-group component of variance. The total is the sum of those two pieces. The interclass correlation is the fraction attributable to the group or small group or shared intervention agent, depending on how the study is structured. And the variance of the intervention effect is going to be related to that. If groups are established by random assignment, you have the first formula. The variance of the group mean is the usual variance of the outcome divided by the number of participants or members in the group. When group membership is not established by random assignment, and this would be the individually randomized group treatment trial or the parallel group randomized trial, you have the residual error divided by the number of members in the group, but the group component is not divided by anything, and so it just sticks out there. Another way of writing that expression is shown on the bottom. It's the usual variance for the group multiplied by this variance inflation factor, which is comprised of the number of observations per group and the interclass correlation. M is always going to be a positive number, greater than 2. The interclass correlation is usually positive, and so that parenthetical expression is positive. And whenever it is, the variance in this kind of situation will be larger than in the RCT, where membership is established by random assignment. Nested factors must be modeled as random effects. If they're not, you're going to have an inflated type 1 error rate. The variance of any group level statistic as a result will be larger. The degrees of freedom available to estimate that statistic are going to be smaller because it's based on the number of groups, not the number of participants. One of the first studies I was involved in was the Minnesota Heart Health Program. This was not a randomized study, but it was a very large, and at the time, the largest grant ever awarded to the University of Minnesota. This was 1980, so a long time ago. We had 6 communities, 3 and 3. We measured 20,000 people across those 6 communities. Terrible design, would never be funded today. I can say that safely because I neither designed the study nor voted to approve it. But I did work on it for 15 years. First as a postdoc and then later as a faculty member, and at the end of the day, I was in charge of the evaluation activities. That study would never be approved today. It was silly to have 6 communities and 20,000 observations. We should have had 20 or 40 communities and a few thousand observations. Would have been much better. So degrees of freedom are based on the number of groups, not the number of people. Any analysis that ignores either the extra variation or the limited degrees of freedom is going to have an inflated type 1 error rate. In parallel group randomized trials, it could be 30%, 50%. In individually randomized group treatment trials, it's not as bad. It could be 15, 25%. Extra variation, limited degrees of freedom always reduce power, so you need to take these things into account when you're planning the study. How about stepped wedge group randomized trials? Well, because we cross groups with study conditions or study arms, the impact of the interclass correlation is much reduced. If it's possible to cross therapists with study conditions or other factors that might otherwise be nested, it's a good idea. It reduces the impact of the interclass correlation, and this is one of the advantages of the stepped wedge design. Even so, there are other potential sources of bias that we need to be worried about. As I mentioned before, the intervention effect is completely confounded with time, and so we have to adjust for time in any analysis. The intervention effect may vary over time. It may develop rapidly and be substantial in the beginning and then fade over time. It may vary by group. Some groups may respond more to the intervention than others. The patterns of correlation could vary over time because stepped wedge designs tend to run longer than parallel group randomized trials. Any analysis that assumes that the intervention effect is constant over time, across groups, and that the pattern of correlation is constant may be biased. So these are things that you need to think about and consider as you're planning the analysis. Compared to a parallel group randomized trial, stepped wedge designs are at greater risk to the effects of external events. And some of you have had experience with that in the Collaboratory. And one of the main reasons is that they're longer, usually. The other main reason is we don't have many control observations towards the end. And if something else happens out in the world that could affect our outcomes, we could be stuck. Where in the parallel group randomized trial, we still have a solid comparison arm, and it's a little bit easier to deal with it. Jerry Cornfield wrote a paper in 1978. I always talk about this paper when I talk about this material. This is one of my favorite quotes. Randomization by cluster accompanied by an analysis appropriate to randomization by individual is an exercise in self-deception. I love the understatement. So you've all been warned. Don't do that. His remarks were directed specifically at group randomized trials, and this was the first paper that appeared in the biomedical literature talking about group randomization. And the title was Randomization by Group of Formal Analysis, and it's where I came up with the term group randomized trial. Alan Donner chose to use cluster randomized trial, and he's been much more successful in promulgating that term than I have been with group randomized, but they mean the same thing. So even though Cornfield's remarks were addressed to group randomized trials, they also apply individually randomized group treatment trials and to a certain extent to step wedge. The RCT is the best comparative design if individual randomization is possible without interaction post-randomization. An individually randomized group treatment trial is the best comparative design if individual randomization is possible, but there's a darn good reason to deliver the intervention in a group format, and often there is, or through a shared intervention agent. The group randomized trial is the best comparative design whenever the investigator wants to evaluate an intervention that manipulates the social or physical environment or can't be delivered to individuals without risk of contamination, substantial risk of contamination. And then finally, the stepped wedge is an alternative, but we need to be sure that preliminary evidence makes it unethical to withhold the intervention. So we understand that we're not likely to have negative effects. It's impossible to implement the intervention in all groups simultaneously, and external events are unlikely to affect the outcomes before the end of the trial. If we don't satisfy those conditions, I would encourage investigators to reconsider the stepped wedge and take another look at the parallel group randomized trial. So how do we choose among these? I'm working on a paper with Monica Talliard and Liz Turner and Stephanie George, and this was one of the issues that we considered in this paper, and we came up with this little diagram that seemed to us to be helpful, so that you're the first to see it outside of our small group. We have three questions that we would put in front of investigators to consider. Does the investigator have control over whether each participant receives the intervention? And by control, we mean if I cannot deliver the intervention to individuals one at a time, if it's going to go out to a large mass of people and I don't have control over that, then I don't have control. If there is high risk of contamination where intervention participants are going to interact with control participants and may share some of the information or material, I don't have control. So I only have control if I can deliver the intervention to individuals without substantial risk of contamination. And if that's true, then I can consider the second question. Are participants within either study condition, my intervention arm, my control arm, are they expected to interact in any way post-randomization? And that could happen if they're going to meet in a small group. Maybe it's a weight loss study and they come on a Tuesday night to get their weight loss class, or a Saturday afternoon to get their weight loss class, or a smoking cessation study. Again, they come on a Wednesday night or a Saturday afternoon and they interact with one another as part of this small group getting their intervention. They could interact through a virtual group. I've seen this many times. Everybody in the intervention arm gets access to a chat room and they interact with one another online. They could interact through a common intervention agent. Maybe they don't meet face-to-face, but there are many psychotherapy trials where there's a limited number of psychotherapists involved. They each see 20 or 30 patients. So that's a way of interacting indirectly among the participants. They're doing it through an intervention agent. Such interaction could occur in one condition, in both conditions. If I don't expect any of that kind of interaction, I can use the randomized controlled trial, individually randomized controlled trial, and I should. If I'm anticipating interaction, then I should be looking at the individually randomized group treatment trial, because I'm set up for that. If I don't have control over whether each participant is going to get the intervention, then the second question that I should consider is, must all groups or clusters receive the intervention during the trial? I'd like to avoid that if I can, because I can use a parallel group randomized trial, and that's a stronger design. But there may be ethical, political, logistical reasons to deliver the intervention to all groups before the end of the trial. I've just gone through an exercise with NIDA looking at the Healing Communities effort where they funded 4 states. Each of the states is supporting 15 to 17 sites. They want to reduce opioid overdose death rates by 40% over 4 years. I argued strongly for a parallel group randomized trial, but the states weren't interested in that, and of the 21 applications, 20 were stepped wedge group randomized trials, and 1 was a parallel. So one investigator agreed with my logic, and the others thought that there were ethical, political, or logistical reasons to deliver the intervention to all groups before the end of the trial, and went with stepped wedge. So that certainly can happen, and if that is the case, then that's the design of choice. What about analytic methods for these studies? We know from a variety of papers published over a couple of decades now that mixed models work very well for group randomized trials, whether parallel or stepped wedge, and for individually randomized group treatment trials. For the standard group randomized design, the parallel group randomized design, if I have a pre-test, post-test design or a post-test only design, I can use a mixed model ANOVA or ANCOVA. I can look at the post-test adjusting for baseline or the post-test alone, or I can do a net change or repeated measures ANOVA, ANCOVA, looking at pre versus post change. All of those models, if implemented correctly, will have a nominal type 1 error rate, and they're perfectly reasonable to do. I can fit them using the general linear mixed model if I have continuous outcomes, or the generalized version if I have dichotomous or count data. And there are many sources on these methods, so I can recommend them wholeheartedly. If you have more than 2 time points in the design, and you could have 3 or 4, maybe 1 baseline and several follow-ups. If you're only going to look at baseline at 1 follow-up adjusted for baseline, you can use the methods I talked about a moment ago. But as soon as you want to put 3 or more time points in the analysis, then you need to look at what I call random coefficients models, also called growth curve models. Now the time points are modeled time is modeled as a continuous variable rather than categorical. And the intervention effect is estimated as the difference in the trend estimated for the intervention arm versus the control arm. Simulations have shown that this approach has a nominal type 1 error rate across a wide variety of conditions that we see in group randomized trials. And the previous class of models, the classical repeated measures mixed model ANOVA, has an inflated type 1 error rate as soon as I have 3 time points or more. So a cautionary note there. What about individually randomized group treatment trials? Well, the problem with interclass correlation, or the effect of the interclass correlation, isn't as severe because it doesn't exist at baseline, but it does develop over time. And the type 1 error rate can exceed 15 or 20% easily enough. The solution is the same as in a parallel group randomized trial. Analyze the data to reflect the variation attributable to the groups. And mixed models are the most common approach. What about a situation in a group randomized trial or an individually randomized trial where people change groups or clusters over time? I'm not talking about changing arms. They don't move from intervention to control, but they may move from a junior high school to a senior high school. Several junior highs could merge into a senior high. Some students could change from one junior high in the control condition to a different junior high in a control condition. Or in the individually randomized group treatment trial, participants could get some of their intervention with one therapist or intervention agent, other parts of the intervention through a different intervention agent. They could be part of a couple of different small groups or even large groups as the study rolls on. So the methods that I talked about a moment ago are fine if people don't change or aren't members of multiple groups, but as soon as we have the multiple membership or the cross-classification, then we need to consider different methods. And there's several papers cited here that describe those methods, and I would recommend these papers to you if you're looking at that kind of situation. We know from simulation studies that if you ignore these issues, you're going to have an inflated type 1 error rate, even if you're doing the other things right. So you can't ignore cross-classification or multiple membership. What about stepped wedge? My comments previously have referred to group randomized, parallel group randomized, and individually randomized group treatment trials. In stepped wedge, we have a series of papers beginning with Hussey and Hughes from 2007, working on through a series that I'm going to show you here in 2 slides. These methods are evolving. This area is much more active in terms of methods development than other areas. It's also much newer. The original methods assumed that the intervention would have an immediate effect, and that effect would be a constant and unwavering throughout the rest of the study. I think that's an unrealistic expectation. And the more recent papers have considered, well, what happens if the intervention effect changes over time, or what happens if the correlation pattern changes over time? All of those things are possible. So Hughes et al. Allows treatment effects to vary across groups or over time. Hooper allows the between period ICC to be less than the within period ICC. Kazaa allows between period ICC to decay, and Grantham allows even more flexibility in decay patterns. So all of these papers are making headway. There's still lots of room, though, for work here. So if you're a methods person interested in this sort of work, this is a target-rich environment. State of the science for analytic methods. We need to reflect the nesting that exists in these designs, whether it's complete or partial, sometimes cross-classified. Used alone, methods based on the general or generalized linear model are not valid. If we use the mixed versions, we can get a valid analysis. Other methods can be used, like two-stage, GEE, randomization tests. These are all methods that can be used effectively, but you have to do it correctly, so you have to be careful. How about power? Well, the usual methods have to be adapted. We can't calculate power for any of these studies like we do in a traditional individually randomized group treatment trial. There are lots of papers on power for group randomized trials, and a good resource is this research methods resources.nih.gov. So I recommend that to you. It's got lots of background material, a sample size calculator, and there are other sample size calculators available that you'll find online. Individually randomized group treatment trials, the methods have been published, and here are a few of the papers. You all, I think, have access to these slides, so you don't need to be furiously writing anything down. You have the references. We also have methods for stepped wedge designs that are published, and more papers appearing all the time. NIH resources that are available in this area, I list some of them here. There's a 7-part online course on group randomized and individually randomized group treatment trials available on the ODP website. There are Mind the Gap webinars that are available. We have the Research Methods Resources website. The Collaboratory has the living textbook and lots of materials, and you'll find other things out there as well.